And as ever, I think we're live, but I always feel a bit cautious taking that for read, just because it tells me I'm live, I'm not sure, but hopefully we are live for our MMU webinar. It's a Physio Matters production, and this is with MMU. We've been doing a couple of these in-person events with MMU, which is only up the road from us and our HQ. We did one with Joe Gibson, one with Mike Callahan, and then of course we all got pinned to our desks in home. And so we're going to do this virtually and bring this together. And because of that, the topic is, of course, in keeping with the current situation, which is how we're making adaptations to physiotherapy consultations. And so Jane Ashbrook, who I'm going to introduce in a second, has brought together a great panel for you tonight, who's going to be presenting some material and having a Q&A in which I'll be grilling them on what they've talked about, as well as the broader theme of virtual consultations. So welcome to those of you that are joining us live. Hope you can hear us and hope you can interact with us on the Facebook chat function. Please do be putting your questions on there as much as possible. And don't worry if we're not getting to them right away. We will have questions after each speaker and also bring it together as a panel best we can towards the end as well. We've got 2 hours, we've got plenty of time, but the theme deserves it, the topic deserves it. So thanks for joining us. Looks like we're getting more and more people joining live. That's fantastic. Welcome. Do make sure you use the chat function throughout. Make sure you let us know if there's any tech issues, but it sounds like everything's going to be crisp and the rest of the gang are all joining. So that's brilliant. I'm going to bring them in a second, but actually first I want to bring you the lady who's made it all happen, Jane Ashbrook. So we hit gallery view. Here we go. Jane.
Good evening. Hello there.
If that's working, lovely. So tell us a little bit about this session and how it fits within the broader MMU CPD calendar.
Okay, well, so we try and do 1 or 2 a term evening seminars with local experts coming to talk to students, alumni, local physios at the university. But obviously, because of recent situation, Brooks Building is shut. So we are no longer based at the university, we're now all based at home. So we thought we've got one more seminar to do before we break up for the summer. So we thought, what better topic than technical solutions to physiotherapy, since we're all having to learn on such a steep learning curve. We've got some really good speakers tonight. So we're going to kick off with Andrew Cuff, who's going to talk to us about video consultations. And then Gemma Oliver is going to talk to us about telephone consultations. And we've got Steph Hewitt, who's here to talk us through some apps that we can use in management of MSK disorders. And then finally, Pamela Scarborough, all the way from Sydney, Australia, is going to talk us through how to optimize engagement with online exercise. So I'll introduce our first speaker, which is Andrew Cuff, who's a consultant physio at Connect Health. But he's also a PhD student with us at Manchester Met. So it seemed very fitting to ask Andrew to come and speak to us tonight. And he also uses video consultations fairly regularly as part of his role with Connect. So over to you, Andrew.
Brilliant. I'll try sharing my screen. If you could just let me know if it doesn't present. So you should be able to see my slides, and I should be going into PowerPoint now.
That's good. Yeah, we're getting that.
You want it? Fantastic. Very good. Cool. So Jane, thank you for the introduction. I've kind of rejigged the order a little bit because I have to jump off. It's pretty much soon after I presented because it's the first cricket training session of the year. So do get your questions in early. I won't be around for the grilling at the end. So I'm going to talk a little bit around some tips and tricks for effective video consultations. And Jane also asked me just to talk a little bit around serious pathology and to reflect on whether or not video consultations are an appropriate medium for identifying and managing serious pathology. So a little bit about myself. As Jane mentioned, I work as a consultant physiotherapist for Connect Health, and I'm the clinical lead for the north part of services, which kind of covers off from Wolverhampton as my kind of furthest south, Northumbria, furthest north and then as far east as Lincolnshire. When I'm not with Connect, and well, as part of my Connect role actually, I'm a PhD candidate at Manchester Metropolitan University, where I work alongside the team, undertaking some research into diagnostic imaging for musculoskeletal conditions. My clinical interests are varied, but predominantly right around the upper limb and spinal serious pathology. And quite ironically, one of my clinical interests is ending body part silos. So I'm not sure quite how long we'll go on to identify as such, and that'll be part of my Therapy Live talk in the coming weeks. And from video consultations perspective, I've been using video consultations predominantly privately for the last 3 years, and in the last kind of 3 or 4 months I've been using them with Connect. And like most of you watching this, I've been using them a lot more frequently recently. The aims of my kind of brief talk tonight is to discuss the role of video consultations within contemporary MSK practice, discuss some tips and tricks, and to consider how serious pathology can be successfully detected whilst working remotely. I'm hoping that in terms of a learning objective perspective, that you'll be able to identify why a video consultation is appropriate and where it adds value to the clinical encounter. Hopefully will improve your consultation skills when undertaking a video consultation, but this does require practice. And to be comfortable with identifying and managing the care pathway for somebody with suspected serious pathology whilst working remotely. So to give a little bit of background to remote consultations, they're not new. I know Jen will be talking about this in a little bit more detail later on, but telephone appointments have been around for over 20 years. And we know that video appointments have been around for over the last 5 years. And I think the most well-known examples of this is the Oxford Foundation Trust linking Skype up within 2015. But then naturally, as COVID's come along, this has resulted in rapid and transformational innovations. And we often see that COVID is provided an opportunity. We've had to prioritise the transformation of a lot of digital innovations. And in some part, that's been driven by necessity. Now, there's some figures at the bottom of the screen here that are being well quoted at the moment. A few months ago, February 2020, 1 in 10 primary care consultations were virtual. And then fast forward to May of 2020, 9 in 10 primary care consults were virtual. Now, this is likely nonsense. I've not seen any supporting data, and the accuracy of these figures has been questioned. But what's probably quite clear is that we're definitely using tech and we're using video consultations now a hell of a lot more than we used to. And the likelihood is they're going to stay in some part of our service delivery going forward. To highlight how that data may not necessarily be accurate, we've seen some reports that primary care has seen a reduction in online consultations during COVID, which I think a lot of you might reflect and think that sounds probably unlikely. So the first question that I kind of invite you to ask yourself is a video consultation necessary? And the answer to that may depend on where you're working and where you are in that part of the patient care journey. So if you think about care setting, if you're seeing somebody in primary care versus seeing somebody in tertiary care, the use of video consultation may not be appropriate as a first port of call within primary care. We may also want to be thinking around NHS setting versus private practice setting. A private practice setting we're seeing in online or out there in practice are more readily using video consultations over telephone consultations. And there's probably some nuances and challenges behind that, particularly thinking around in the NHS, you have access to the clinical records, the clinical notes, you know a hell of a lot more about the patient than you might do from private practice. And this is probably the reason why, and it's reflected in NHS England guidance, that telephone consultations should be the default virtual option, remote option used during COVID. So when we ask ourselves the question then, what value does a video consult provide? And I'm going to ask the question if Jack or Jane can ask if anybody puts an answer into the chat function. But if you think about video consultations, they'll have positives and they'll have negatives. If we just start off focusing on the negatives, what do people view or what have people found to have been negative as part of their experience recently with video consultations? And I'll just give you a few moments to get something into the chat.
We do have a slight delay to the feed, so that's just something that we're going to need to just hover on for a second. So please do get your comments in there, and we will feed them into Andrew. But there will be a bit of a delay to this, so especially if you're watching back, and forgive us for that. But we just need to pause just to try and make this a bit more interactive.
Got anything coming through, Jack?
We're getting a few bits.
Very good.
Negatives if the tech's not working.
Yeah, definitely.
Lines cutting off, audio difficulties. Then there's people then suggesting people in private practice struggling to keep people engaged with video consultation now that they're opening up clinics, and that feels disappointing that they've not been able to maintain that. So it feels like it has been just a stopgap, is a suggestion.
That's interesting, and I think it probably reflects back to different care settings as well, isn't it? In the CSP guidance, NHSE guidance is very much we should still be taking a virtual approach. I suppose that's maybe a bit more nuanced in private practice if you do have capacity to go back to face-to-face.
Digital literacy of the client and patient, delaying the technology, talking over each other accidentally, so you're interrupting more.
Very good.
Is then difficult to perform neuroscreen. I've got a sense that you might come to that, mate. Some patients don't like it. Lovely comment there from Vicky Ashworth.
Yeah.
Sometimes definitely well worth us thinking about that for sure. Generally very positive in the NHS, and patients pleased to hear from you. Main problem is the difficulty getting through to people, so digital DNAs. No,
fair enough, absolutely. And if I just switch the question there, so thank you for putting some negatives in there. Let's finish on the positives. What are the positives of a video consultation, or what positives have people seen from a video consultation?
There's a really good one here from Sophie that is saying the opposite. So somebody had said about difficulty getting the right video angle, but then somebody else has said, but actually getting a spouse involved or a family member involved is a positive thing with engagement.
Absolutely, absolutely. And I suppose I'll come on to it, but other people in the room can be a positive or a negative. And I think a lot of the kind of positives for video consultations can also be negatives for video consultations.
Vicky's saying that you can physically see the patient and they can see you, and therefore that just makes it that bit more personal. I imagine she's comparing that to say telephone.
Absolutely. So the non-verbal communication ability to pick up visual cues, absolutely. Then
Katie Napton, obviously an expert in this field. Simple, fantastic resources. Screening is easy. If patients are won over, it can be easy to book and engages them digitally.
Absolutely.
Patient gets to put a face to the name, increasing trust and reassurance in quality assessment. That's from James McDonald. And then improving rapport compared to telephone for the reasons you've just mentioned there. Also, Dan Bentham's mentioned that it's a more efficient use of time.
That's an interesting one. It'd be interesting compared to face-to-face or compared to telephone. I wonder if Dan could come back as we move on about and just clarify that. But I think you could take that one either way. But just to move us on, I think a lot of the negatives and positives have been covered there. And I think one of the big positives to me, and particularly from reflecting my experience with Connect Health, we've used telephone consultations for a number of years, and some people love them. There was a comment there that's saying that video consultations, some people just don't like it. But one of the issues that seems to come up with telephone consultations is, well, how can you possibly assess me if you've not seen me? And obviously that barrier is removed somewhat with video consultations. And what's interesting is looking through the data suggesting around how many consultations have been used either via text or via telephone or via video. It's been shown in the last 3 months, particularly within primary care, that text and telephone consultations have been used a lot more readily than video consultations. And part of the reasons offered up for this is that people have to set time aside for video, where you can be out and about, you can be driving and doing a telephone consultation, as long as you're on Bluetooth, obviously. But then also the fact that video is maybe a newer technology and telephone seems to be a lot more familiar. And there may even be something about equitable access. A lot more people have access to a telephone than they may do to a sort of smart device. I'll move on. So moving into kind of consultation skills and the second learning objective of trying to just improve your ability or improve your abilities and competency within virtual consults. I lean very heavily on some of Trish Greenhow's kind of original research from 3 or 4 years ago and combine this with some of my own experience. So before you start your video consultations, have a little bit of think about the room that you're in, ensure that it's well lit. And a couple of things I'm sure everyone's finding from remote consultations and remote meetings is try not to sit in front of a window because you look like a shadow. And something that I learned quite quickly when doing video consultations is to do it so your background doesn't have whiskey bottles behind you. It doesn't necessarily look the most professional when you've got a bottle of Jameson's over your left shoulder, although sometimes needed, particularly on a Friday. Contingency planning. So making sure there is a telephone number, and this will depend upon your operational process and pathway. So for example, within the NHS, with telephones being a default, it may be that you've started the consultation on the telephone, then you convert to a video consultation where you think it's necessary and where you may add value. So in that case, the contingency plan less crucial. But it may be in a setting where yourself and the patient are actively dialing into the video consult as the primary mechanism of communication. So either ensure that you've got the patient's telephone number, and if you haven't, ensure that when you start the conversation that you do obtain the telephone number. Check the technology is working prior to the call, make sure your camera works. For some reason, when I log into Zoom, I'm always upside down, so I have to change my settings. But depending on some of the platforms that you use, they're not overly compatible with different types of browser. So for example, Internet Explorer may not be compatible, whereas Google Chrome or Firefox may be. So just ensuring that technology works for you. And if you are doing a lot of consultations remotely, particularly if you're working from home, investing into a second screen is a solid investment. And able to see the patient on one screen and to have your clinical records on another screen just allows you so you're not flicking between the two, which can sometimes disrupt the flow of the consultation. Can be really important. So if you think about then starting the conversation, check that the person can hear you and that you can see each other. So simple things like, can you see me? Can you hear me? And is the video angle correct? Can you just change if your patient is sitting in front of a window, ask them to move, to optimize that clinical setup. I think somebody mentioned around trust and reassurance. One of the things that I've started doing at the start of a video consultation when introducing myself is just putting my name badge up to the screen, so they can see who I am. They know that I'm calling from a somewhat reputable source, and that we're going to have a consultation. If you're doing video consultations from clinic, it may be appropriate to introduce everybody that's in the room to you so they know that you're not alone, and also ask the patient to do the same, so even if the people at home are off camera. I always think it's important to understand where the patient is, and for a couple of reasons. First one, thinking from a safeguarding perspective, if there's an issue whereby you might need to call the police, then it's important you know where the patient is. But also, if the patient is seriously unwell or you're concerned by the patient from a clinical perspective, then it might be important that you might have to send an ambulance to that location. It's important then to orientate the patient to a video consult, to reassure them that the consultation will likely be very similar to a traditional or to a standard consultation, but also that the call is confidential and secure. We know that, as Jack's mentioned, I think it came up into the comments, you're more likely to talk over one another if there's a slight delay, or the picture might go a bit blurry. So to preempt that, and it's something that I refer to on the screen here, is no, you go. And if we start talking over one another, I'll stop talking, you carry on, and we can pick up afterwards. If you haven't got that telephone number, or if it is a video consult, just ensuring the patient's aware of the contingency plan. During the consultation, once you've orientated the patient, you don't need to keep looking at the camera to demonstrate that you're engaged. I mentioned the second screen, and one of the things that I'll commonly do is say that I've got your medical notes on this screen here. You may see me and my attention look to the left. I'm still listening, but I'm looking up something in your medical notes. Or you may see that I'm writing something down that I think is pertinent. All these things that they would be mindful that you do in the traditional consultation, but naturally when your attention is focused, it's useful just to preempt that and orientate that. In terms of objective examination, demonstrate, get up, move around, keep the instructions clear and concise. So for example, can you raise your arm above your head, and demonstrating to do so. And it's really important as well with your objective examination that you consider the clothes that you're wearing and not to get caught out. We have a professional looking top half, but then you have to get up to demonstrate something and don't necessarily have a professional looking bottom half. I'm sure there's been a few clinicians caught out over recent weeks doing consultations in their pajama bottoms. To end your consultation then, so I think there's a lot here for ending a good consultation anyway. Summarise and play back as usual, but probably just even more important when doing a video consultation, in case there's been any form of technical interference or a glitch or something that's been missed. Ask the patient if they need anything clarified or if they're happy with the next steps, and always asking the question of, what further questions do you have for me, rather than do you have any questions? And that subtle change of asking the question can elicit some information from the patient that may not otherwise have come forward. And one of the final things, kind of tips and tricks, is to let the patient end the call before you do. And I find that that last minute question that someone's got, or if they're having difficulty with technical literacy, I'll often just guide them through that to the end. So if you look on the right hand side of your screen, you'll see a button that says leave meeting. If you want to leave the meeting by clicking that button, and once you've left, I will leave as well, just in case you've got any questions or any difficulty. So that's the second objective of our kind of consultation skills. Before I move on to the end of my talk, which is talking about serious pathology, the question I just again would like to pause and to put into the chat your answers is, when would a remote, and that could be telephone or video, but particularly focused on video consultation, not be suffice? For those wondering how my cricket training might be going after this, it's absolutely pissing it down with rain. So there may not be any cricket training after this, but I might jump back on later. So
yeah, we might get you for a little bit longer. That sounds good.
Absolutely. Anybody in the chat there, Jack, about when a remote consultation may not be suffice?
Just getting things going. Just coming in from this. I think the perception is that certainly neuroscreen comes up quite a few times, not just on this, but historically when talking about this issue, as well as then swelling has been mentioned, or those other features that are sometimes difficult to view, anything where palpation feels necessary. There's then a great comment coming about safeguarding, where it's sort of difficult for us to do that grey area that you face as a clinician, whereby you might be sort of recognizing something's amiss and having your policies to deal with that. It sort of throws up new challenges there. Cauda equina syndrome, especially for those that might feel it's necessary to do what would be more intimate exam for the sort of sensation or perianal tone, sorry.
Lots of comments about neuroscreen, and also examine for pathology for example, a hot swollen joint.
Okay, absolutely. So so as to not use up too much time, I'll move on, but I think that lots of kind of common concerns and worries, and I think probably some anxiety as well in clinicians when it comes to some of those pathologies. So as you say, looking at a swollen joint or performing a neurological examination, or the intimate examination that you alluded to, Jack, of you're going to do your PR tone or subtle sensation testing. So let's see if we can pick some of those things up.
Lovely point. I think you'll like here, sorry, Andrew, is a point from Trevor Lewis about vascular assessment, particularly pulses, which when it comes to serious pathology might be a high-end sort of example. Yes, no, absolutely. Thank you. So if we focus this around COVID and what NHS England have defined as serious pathology. So on the left-hand side, you've got your emergency conditions, and on the right-hand side, you've got your urgent conditions. Now, NHSE have defined emergency as same day. In this particular guidance document, they haven't mentioned a timeline for what constitutes good urgent management, but you can cross-reference it with some of the other previous documents, somewhere being less than 72 hours. And the reason why I put an asterisk next to the major spinal-related neurological deficit
This was defined within that guidance document as muscle power less than grade 4. And I just want to leave that point there as we consider a virtual neuro assessment going forward. We also, alongside serious pathology, have specific pathology. And some of you may have seen the surgical prioritisation guidance from NHS England, which has categorised referral on into specialities as 1A, 1B, 2, 3 and 4. And the ones that kind of fit into this specific pathology and time-sensitive pathology are outlined on the screen there. So you've got your same day and your less than 72 hours. So compartment syndrome, open fracture, consideration of fractures, whether that be pathological or periprosthetic. Those of you that may have heard me speak about red flags before, you'd be familiar with the clinical seesaw that I talk about. You know, with every piece of information that comes in with a consultation, whether that be kind of a subjective piece of information provided verbally, whether that be an objective examination piece, whatever it is. The reason why the seesaw analogy I like is because as that information comes through, your index of suspicion should either go up a little bit or down a little bit. And as your index of suspicion goes up, your threshold to do something about it should go down, and vice versa. And when you get towards the end of your consultation, you see your seesaw will be one way in the direction. If your index of suspicion is high, then your threshold to do something is very low, and vice versa. Laura and the team at iFont have recently published their red flag guidance, which builds upon this concept and provides a few extra layers of detail. So just to orientate you, the picture on the left is regarding determining your level of concern. So if you consider the evidence to support red flags, you consider the individual profile of that person's health. So it could be their age, it could be their gender, and it allows you to decide your level of concern or your index of suspicion about the presence of serious pathology. The figure on the right then helps you decide on your clinical action. So based upon your level of concern that you've determined from your first step, that picture on the left, and then you put the two of those bits and pieces together and you consider the pathway, your local pathway that you work within regarding emergency and urgent referrals. And one of the things I think is really important at the moment is whether you're working in the NHS or in private practice, is knowing the local referral pathways, knowing what specialities you have access to that are working. How do you get these urgent patients in? How do you get this patient imaging if you need to? And this is something I think over the last 2 or 3 months, there's been a lot of conversations between primary care, intermediate care and the specialities to ensure that these urgent emergency pathways are still open for patients that need. So where does video consultations fit into this? Now, I would propose that where video is available, the majority of above conditions can be successfully identified and referred, or reframe that, particularly your index of suspicion should be peaked enough, where the question I would ask is, how does a physical examination sufficiently change your index of suspicion towards your management? I can't think of too many examples where my suspicion would be altered based upon an objective examination. We always talk around serious pathology in peacetime as well as in COVID time. The majority comes via your subjective assessment rather than your objective assessment. So how would a physical exam change your management? Now, I preempted that the question may predominantly be around neurological examination, and particularly, as mentioned, I'm going to highlight here is around local pathways. But if we think about neurological examination in a real practical sense, we think of sensation, muscle power, and reflexes. Sensation, we can quite simply talk a patient through a light touch sensation examination using video. If there's a family member present that has been mentioned previously, you may even pull that family member in to look at doing sharp blunt testing for small fibre detection, should you feel that appropriate. You can do that for the upper limb and the lower limb. If we think around myotomes, as mentioned, that significant spinal related weakness, less than grade 4, that's an active movement without resistance. We can see somebody if they can lift their arm up or move their arm out to the side if they're working at grade 3. And if you have got a family member to apply some resistance, then you might be able to think about, can they push against resistance? We said definitely at least a grade 4. You can utilise the video to also look for any wasting as well, which may take a little bit of playing around with the camera angles. But again, a family member can be really useful in that circumstance. So there's things we can do in terms of initial threshold that just involves you and the patient. And there's a threshold above that where you could bring a family member into play. If we also think around the lower limb, we have functional assessments of myotomal strength. So can the person hill walk or toe walk, which will cover off kind of the L4 to S1. Can they do an assisted squat, which gives you an idea of L3, for example? And a little bit trickier, but not impossible. Might be then thinking about more upper motor neuron pathology. So you can see if somebody can do a finger nose test with the family member, or can they get the family member in to do clonus? If that family member isn't available, can they do a heel shin test? Can they stand with their eyes closed and check their balance if you think you can safely set that up? Can you position the camera to watch them do some tandem walking and looking at their coordination? Now, the reason why I've mentioned local pathway here is it's important to understand thresholds for those that you work in. You can think of an example of the last 2 or 3 months. We've had a patient, we were concerned by the neurological deficit, we thought they needed an MRI scan, but the radiology department that were operating urgent imaging only would only do so if they've had a face-to-face neurological examination. So you do have to work within your local pathway. But you should get sufficiently, if you think from an emergent perspective, if we use the example of cord recliner, the majority of the information there is going to come from a good subjective examination. The objective examination is probably not going to lower my index sufficiently enough to stop me referring that patient along the emergency pathway. So for some further reading references around virtual consultations at CSP quite early on in April, the document around top tips for remote consultations, and Trish Greenhow, who's been phenomenal over the last few months about helping people rapidly implement video consultation and building on that in terms of video consultation skills. So that's my last slide, so thank you if there's any questions. I'll stop sharing my screen, and if I can work out how to do that.
I can do that, I think. I can kick you out.
Brilliant.
I think
Cheers,
I can kick you out. There we go. Okay, so hopefully we're back on speaker view. Now, Andrew, how's the weather there? And you know, how long have we got you?
You just see someone's just started walking their dog, so I think it's fine.
Yeah, okay, well, we'll try not to keep you too long. Thank you so much for that. That was brilliant. One of the core questions that I have when it comes to this is that when it's serious pathology, people find that is something that ramps up their specificity over what they personally find they want to meet their threshold, right? When their index of suspicion tips towards referral. And so then I think people then, rightly or wrongly, get sort of spooked into thinking, normally I would do this, and I would really value that very real-time feedback as to whether or not, how much they can resist me through that, be that a dorsiflexion or knee extension or whatever it might be, that I really struggle to emulate. Do you think that is an indication that people are just putting too much on their habits, or do you think there's actually, you have some sympathy in that direction, that it's quite difficult to emulate?
I think probably an element of two answers to that, Jack, really. The first one being that I think it's probably an element of habit, but I also think over the last 3 months that a lot of us have gone on a journey where we realise that our subjective skills are definitely could be better than they probably were. And we've also probably realised that a lot that we were reliant upon probably hasn't added too much value to our assessment, and it will probably change us going forward when we do return to the new normal. I think one of the things that I'm particularly mindful of is just around managing uncertainty, and I think that becomes a little bit of I think thresholds have been changed since we have moved towards more kind of virtual consult. But previously we might make a referral, or we might order an image just in case, you know, it's a bit grey, but are on the safe side. And we've had to move into a space where we can't really err on the safe side, because the risk of doing that may actually outweigh the benefit related to the condition or concern that you're worried about. So I think we've stopped and we reevaluated habits, and I've seen a lot of Christians reflecting on this. And I think serious pathology is one where that's really been highlighted, particularly when we get so engrossed in the world of MSK. But what we see as kind of urgent conditions sometimes aren't urgent when we speak to other specialities. So to move away from the spine, I think a really clear example is things like avascular necrosis. You know, if we see avascular necrosis of the hip, we order an urgent imaging request. If we get the imaging back, we send it to orthopedics urgently. But particularly now more than ever, if you speak to the orthopedic guys and you pick up an AVN, and I don't know what it is about COVID, we've had 5 AVNs in our service in Yorkshire since the pandemic and lockdown started. Orthopedics are quite You see how they go. Refer them when we're back open again. And I think it's just highlighted to us to take a step back and look at thresholds and really, is it really urgent, or is it physiotherapy urgent? And I think there's two different things there.
Yeah, I've certainly encountered that clinically in my career, especially in and around cancer and suspicion over cancer, in that it's something that, especially depending on where you're at in your career and depending on the circumstances of the care delivery setting, I suppose is the word, means that you can sometimes see that as being sort of a couple of career defining patients that might be that you detected something. Whereas when you refer into, say, GP or oncology, it is literally bread and butter, and it's it's a very common problem. So that is really relevant. But then also we don't want to become complacent in that direction just because of the fact that our medical colleagues might see it more and therefore be more comfortable. And also they can act on things urgently. Sometimes we pull the trigger sooner because we know that there is a system that needs to carry over. So it's a really fascinating balance that needs to be had. One of the great questions that we've had come in already is about documentation, and do you therefore offer clarity and caveats within your documentation that explains as to how you carried out a neuroscreen? Yeah,
no, absolutely. And I think, again, leaning on kind of GP literature and guidance recently, the GPs have coded the assessment. There's a code that you can put in, particularly on System 1, which highlights that the assessment has been altered due to COVID. So they can click a button and it automatically goes on. And I think it's good practice to do that, in the sense that this is a telephone consultation, or this is a telephone consultation that's converted to video consultation. And therefore the assessment is within the limits of that being. Do I think that needs to be done routinely? Probably not, for the reasons that I've just described, and that I think most things can be picked up from a video consultation from an objective assessment anyway, if we're thinking non-serious pathology. And I think it would be a bit of an oxymoron, or kind of going back on myself if I said you'd have to put that caveat on every video consultation. But when it comes to some of the nuances like this, or if I'm trying to, if it's a grey area and I understand I'm taking on a bit of risk or managing some uncertainty, then I think it's good practice anyway, whether that be video consult or face-to-face, to really clearly document your reasoning of why you are sending or why you aren't sending. And if that relates to your objective examination, then I think just detailing how you've done it is good practice. So if we think about light touch sensation, I may put light touch sensation is reduced. This was self-reported by the patient under verbal guidance or something to that effect. So I think that's just good practice, whether you're in clinic with somebody or whether you're actually on the other end of a telephone or on the other end of a camera.
Fantastic. No, thank you very much. Now we will let you get to your cricket. I hope it's not rained off. You dart out the door. This is where he stands up and shows that he's already got his cricket pads on, ready to go. Thank you so much for your time. Really appreciate it. I'm going to bring Jane back in to introduce our next speaker. Let you go, Andrew, and feel free to join us later if you need.
Thank you very much, Andrew. That was great. So the next speaker, then, I'm really pleased to introduce Gemma Oliver, who for a long time has been a private physio, sports physio for England Athletics, GB Volleyball, GB Bobsleigh, and made the move about 9 months ago to work as telephone triage with Bupa. So Gemma is kindly going to share her stories with some experiences of managing telephone consultations. So welcome, Gemma.
So just checking you can actually hear me, because
we can hear you.
True seamless fashion, I could pretend that because I'm talking about telephone conversations, I don't need my video. So that would actually work really well. In all honesty, my video is not working. So we'll have a full-on disclaimer, but actually, you know, I kind of think it will hopefully proves my point. So what I'm going to try and do is just share my screen. If it's not working, Jane, Jack, for whatever reason, I have sent it to you if you could load it, but we'll just try, see what happens.
Yeah, let's see. But if needs be, I'll put it through. I've got
Looks
it
to
here.
be okay so far. Just let me know.
Here we go. Yeah, we can see it. Just hit go on that slideshow, and hopefully we can.
Are we there?
That's brilliant. Yeah, we got you, Jim.
Ace. Okay, so in a slightly different, it was really interesting just listening to sort of Andrew and his experience and everything from videos, and I think it's probably brought to the forefront all of the video and telephone consultations that have been happening for a long time, and many people have actually chosen to do this because it's their preferred way of working. But I think we've now, almost been forced into a situation to think of it, and I personally don't think that's a bad thing. Now I can obviously say that because that's my job at the moment, but I don't think it's a bad thing for the profession to start to investigate different ways of treating, and I think everybody's going to find a way that's going to work for them. And I think it's important, as you listen to everybody, this evening, myself and Andrew included, that, not everything works for everybody. You've got to find what works for you. And actually, from my point of view, a combination of all of these things may be beneficial if you're in the environment to be able to do that. So I'll talk about that a little bit more, but that's just a little bit about me. So this is just a little bit about me. So as Jane kindly alluded to, I have had what you probably may say a slightly colourful career in physio, which has been amazing. And I, qualified from Sheffield Hallam, I think nearly 14 years ago now. And it seems amazing to say 14 years, but that is the case. Generally, I've got just a massive passion for people and simple physio, and that will come across in my presentation because I just, I went through many years thinking I had to learn all these skills and I had to do all of these courses. When in actual fact, what I've found that I'm very good at is just the basics, and that's okay. And that's taken me probably about 10 years to realize, but I think it's very, very key when you then start talking about telephone consultations. I love movement. I've put movement instead of rehab now because, again, thinking about a simplicity approach, I just think we need to get people to move more, and there's different ways that we can do that through from various experts that you'll see that have got loads of professional interest in various forms of rehab, to people like myself who have experience in rehab but actually just think that we just need to get people moving. And I also love sort of the concept at the moment about that we are in from a MSK reform point of view, and all the work that Physio Matters is doing about basically just pushing the profession forward. And again, we are in a very unique environment at the moment, but this is maybe forcing us to think about things differently. Okay, so I've worked in MSK ever since. I've never really done anything else. I managed to avoid the on-call rota, which I think is something I might just put on my CV at some point. I started off as band 5 NHS. I did that for a little while, then worked at RAF Cranwell, which was amazing, very different way of working, but it allowed me to sort of think about outside the scope of normal physiotherapy. At the time when I qualified, there wasn't any jobs, so you had to sort of think about things differently, and that's when I sort of launched myself into different ways of working. I've worked in private practice in Lincoln, Manchester and London, and a mix of all three in various clinics, which has been really good. I've done some stuff in the TV and film industry, and then my main bulk of my work, as Jane said, is in sports medicine. So, I was lucky enough to get my first role with GB bobsleigh and travelling, and then I've travelled ever since, really, with Wales hockey and some volleyball stuff, and then contract for British athletics, and I've worked for England athletics since 2012 really now, and that's formed the bulk of my work, which has been amazing, and it's taken me sort of all over the world. But as I'll go on to sort of say in the next slide, it's not always quite as glamorous as you might find. And although I've learned a lot from it, and I've had some amazing experiences, and I've taken a lot from it, it does have a side which sometimes you don't realise. So this is me. These are photos of my first ever travelling job and the last one that I did. So the first one is Park City. It's a bobsleigh track in America. My first fresh face. Yeah, there's a good 10 years of difference in those photos. A few more wrinkles in the second one and a lot more makeup because I was working a lot harder. So, but just gives you an idea that that some of the experience that I now draw on from, a telephone triage consultation, I really do think that although the environments that I've worked in are very different, as you can see from these, there's not a telephone in sight in these photos. It has massively been, it enabled me to be able to draw on these experiences to be able to provide a really good service. And it wasn't something I was always that confident in. And I was initially quite skeptical, and I went into the role for different reasons. But actually, all of these things all feed into the same point. And I think, as I go through my talk, you'll find that this is kind of what the message I want to get across, that although this may be new for some people, or you're looking to do telephone or video consultations, it is essentially the same sort of skill set that you've learned how to do, whether you're a new grad or whatever, and you just need to draw on those skills and bring them into an environment, and it works, it does work. So just carrying on my background, one of the reasons I switched from sort of private practice, sort of face-to-face, and you know, traveling was that I struggled with mental health and some anxiety. This is something I've talked about a lot. It's something now that I'm very passionate about, and I think as healthcare professionals we still don't talk about it quite as much as we do. And for me, it just enabled me to change my pathway and change my focus. I just suffered from some burnout and an overload just of overworking and traveling, you know, which I never resented, but it just took its toll, unfortunately. So I took a break, took a bit of a step back, and I wanted a new challenge. I think this is a whole new different debate, but I did start to get really frustrated with the physiotherapy profession as a whole. About a year ago, I think it may be alongside my own sort of frustrations, but I just got frustrated of doing the same thing over and over, and I didn't feel that we were, you know, developing as a profession. And again, that's a whole different conversation, but that then led me to take a step back and think, okay, what do I like about my job? What are the aspects that I actually really still enjoy, and do I actually want to still do this? Now, obviously this isn't going to be the same for everybody, but I'm just trying to explain the process that I went through from, you know, moving from a very dynamic role in athletics to, you know, just essentially a telephone role. For me, it was a really positive change. It allowed me to, you know, aside the mental health aspects aside, it allowed me to then have a really fresh view of the profession that I actually really liked at one point, you know, and I really did sort of find my passion for physio again. And as I'll go into some different things that I realized I'd developed some quite good skills in, and actually all tuned into, you know, the fact that I could use this for my new job in a telephone triage role. So just some skills and things that I've just to highlight. These are some of the things that, you know, when I was thinking about the talk, you know, what have I learned? And this for me obviously was sports medicine, but this can be, you know, relatable to many people, whether you work in private practice, in clinics or in teams, you know, and then you go into move to more of a video or a telephone triage, you know, maybe just list down some of the things that you know you've learned, and you'd be pleasantly surprised that, you know, a lot of it transfers right across. So my ability to communicate under pressure, I found I was quite good at. You know, I was able to be very flexible and adapt into an environment which you need to be. When you work in sports medicine and even in private practice in a busy clinic, you know, you're working under pressure. I had to be in tune and make quick and accurate diagnostics when I needed to, you know, when you've got the pressure of an athlete that needs to go back onto a pitch or a track, you know, and you've got the coach breathing down your neck and it's important, it actually surprisingly sharpens up your diagnostic skills, you know, obviously within your team. I learnt obviously that I've got people skills which you need in sports medicine and in many areas of physiotherapy, and my teamwork was, you know, good, because it just has to be when you're traveling around and you're everywhere. Knowing when to speak and when to be quiet. I think if anybody asks me what I learnt from sports medicine and traveling with squads, that's probably it's in various, and I learnt that probably the hard way on too many occasions. And being able to think on your feet. You know, I'm not saying I got it right all the time, and I'm not saying I got all my diagnostics right, but it certainly enables you to sort of tune into what you're thinking a little bit more. So my telephone triage role, just to give you an idea of what I actually do, I work for Bupa, as Jane said. It's a team called Physio Line, and we basically triage all the calls. We have half an hour, and I really, really like it. And as I said, it's been a really positive change for me. This is just in very brief the sort of things that we do. So I have a diary like very much as you would do in clinic, and I do a full triage telephone consultation, and we have 30 minutes. So, you know, at first, when I first started, I thought, oh gosh, this is really hard. I don't know how I'm going to do this. And many of the anxieties that many people may face when they're changing this, but actually, you know, it did change for me quite quickly. We are a first point of contact, you know, especially if you have private medical insurance. A lot of people now, you know, you don't need to go through the GP, especially from our point of view. So we are, you know, a first port of call, and this has made me very much brush up on my, you know, some of the stuff that you've mentioned already, and my screening measures, the red flag awareness, the serious pathology, which I think was always there at the back of my mind, but actually from a sports medicine point of view, you don't always need to be that aware of, because there's masses of people that are around you. So that was really good, and that sort of is something I'm quite aware of. You get a very quick diagnostic impression, so you discuss this with the patient. So I do an overall subjective assessment, maybe screen some things from an objective point of view, discuss it with the patient, educate them on the injury, you know, talk about the reason why, you know, the mechanics of as it's happened, and come up with a plan. Okay, and then obviously from my point of view, in my role specifically, which will change for everybody because this isn't my own clinic, I will then discuss with the patient on the next course of action, whether that be self-management and rehab, which, you know, in the majority of the time for simple injuries you can do. So providing rehab and you know, follow-up consultations, etc., or onward physiotherapy face-to-face if we need to, or if the patient feels they want to do that, or actually straight consultation, straight referral to a consultant, which I guess I know in my role is very different if you are, you know, individually doing your own telephone triage. But I think that just highlights to be aware of the pathway, like we've been talking before. Is this a case where then you need to get this person into a clinic, or can you refer them to somebody that can see them face to face, or what is your next option if your telephone and your video consultation isn't being appropriate? And I'm lucky, I work in a large and very dynamic MSK team. I've got people at the touch of a, you know, a Teams or a Skype button that I can ask questions on, and it is very, very kind of laid back. And I think this was a very different sort of approach and a role that I thought I was taking on. I took it on initially because I wanted a break. And you know, it's for me, it's just turned into so much more, and I'm really pleased. I'll pause there for a second. Any questions coming through at all, or anything, or?
Remembering
Can I ask
to
you a question, Gemma?
unmute yourself.
Yeah, you can.
I'm just interested to know, obviously, because you've been doing this pre-COVID as a full-time job. What
Yeah.
sort of percentage of patients do you think you can manage on the phone without then having to refer them onto a face-to-face consultation?
That's a hard question. Without knowing how much I can give away from a Bupa family point of view.
Vaguely, like some.
I think we have, and they're really, really good, and they certainly don't expect you to self-manage or refer. They're a really good company to work for, and they do make it quite varied. We don't have targets as such at all, but I think for me, I think if I can get 20% of my patients to self-manage, and that is a figure that I've just sort of, you know, made up in my head, that I think that's successful. But I think this is what I was talking about before, that the landscape is changing for physio, hopefully, and I think this has pushed us into a new way of thinking. And not just us, but what I found recently is actually the patient's new way of thinking. You know, a patient sometimes go-to is to get a physio appointment, get some treatment and get it fixed. Whereas actually now, when that was taken away from them, not only from a physio point of view, but actually patients have now started to think, well, actually, maybe I can get some rehab on the phone, or maybe I can have that video consultation. Oh, actually, that's quite effective. And now what you're finding is, you know, especially in my role and many other people that I speak to externally, is that actually patients are more willing to take this on board. I know we'll probably go into and discuss people saying that, you know, people aren't getting on board with video, and I know it's not, you know, available for everybody, but actually, you know, patients are aware now, you know, that things are going to be done differently. And I think that was always happening through different people who have different time pressures with work, but actually now self-management is becoming more key. I don't think I've really answered your question, but I don't think I have an answer. But I think, you know, it's very nice for me on the phone to be able to triage someone, give them some exercises, and then talk to them in 7 days and see how they respond. So
do you have to deal with patients saying that they are paying good money for their care and therefore feel fobbed off by telephone?
Do you know what? People don't say that often at all. I think you definitely get a sense of, you know, what people would like. But I think that's the same, you know, whether you're in triage or in a clinic role. You know, people could come into you and say, you know, you could give them all the wonderful treatment in the world, but if they want to go and see a consultant for their shoulder, they want to go and see a consultant for their shoulder. And I think the same applies within our environment. People are generally quite nice as they are to physios when they come on the phone, especially because I kind of kill them with kindness if they start being a bit antsy. But I think at the end of the day, and this isn't just in my current role, I think this is generally, if you don't get them on board and you don't do what they need, what they want to be able to do, you're not going to win them over. And I think there's different ways of doing that. I think in that instance, if somebody was quite persistent and I actually didn't think it was clinically relevant, I would absolutely tell them that clinically at the moment, this was not what we would normally do. But at the end of the day, it is their decision. Now, whether that's slightly different in my setting to private practice, I don't know. I think I've worked in both environments, but I don't think I would do anything different if I was face to face with the patient, because if somebody was pushing back on me that much, nothing I say is going to make any difference.
Yeah, the evidence up to now is, and we're no doubt going to get a spike in the data for this stuff, but the evidence has always suggested that telephone consultations you've got parity on patient outcomes, but not necessarily patient experiences. So it doesn't get rated as well by patients, yet they still get just as better or not as face-to-face care. That's kind of the landmark data that supported some of Leslie Holdsworth's work that's informed policy. Obviously, when we were trying to mitigate that, what do you think are the key variables that will help move the dial when it comes to patient experience?
I think we just need to do it more. I know that sounds like a really simple answer, but you're right. I think we've been forced into a situation where, this is going to be done more. I think people being more confident. I think people making patients aware that actually this is a process. This isn't just something that we're doing now just because they can't have face-to-face. This is something that actually is quite relevant and quite important. And the only real way to do that and to change those surveys and those ideals is actually doing it and showing, and maybe doing, like you say, doing some research and getting some data. All private PMI companies will have their own data, obviously, but, there's no reason why we can't do this in private practice now and start to look at some measures and some outcomes. I know personally, because I follow them through, what the outcomes are generally. It's a different role. We're essentially a triage service, but I think if you're doing it in practice, you'll get a good sense about what's happening. We've just got to do it more. I think we've got to be more confident, and I think we've got to get across to the patient that again, this isn't just something I'm doing just because I'm picking up the phone and I can't do anything else. This actually adds value, and if you can't get out of the house, look at the other things that we can do that are available to you.
Yeah, I think it's going to be really interesting, because there's a cohort group of clinicians that I think would be well worth us sort of studying outcomes of, especially those like yourself, Katie Napton, Evie Martin, Jack March, that have been doing a lot of both triage and consultation based work online, that are then highly specialized in that and also recognize that it is a skill that needs to be honed. The outcomes, when we compare, as well as then the patient experiences, would no doubt be different to those that have had to flex into it, or if a clinician doesn't necessarily value it as much, then that's going to rub off. And so we almost need to tease out and get more data on that. And it'd be really interesting to see if specialized virtual and telephone clinicians are going to be able to mitigate some of those concerns over patient experience.
No, it is interesting. I think when you're on the phone, I think sometimes even on some of my calls, you can see that some of them feel, especially in my role, that it's just a process that they need to go to get physio. Whereas actually, there's no reason for me to not be able to educate them and turn them around. And that's how I feel personally about my calls. It's really nice to be able to talk to these patients. And I'll go on to it, on the slides now, is that, it's nice to be able to talk to them. I've missed, sometimes you miss the opportunity to get this really good subjective history. You can win a patient over within 5 to 10 minutes about the way that you put yourself across, and sometimes that's easier to do in private practice, but actually on the phone you need to be a bit careful about the way you do that. And all those things you've just said are maybe training resources and things that we can develop from people that are doing this more than more. And how do we make this experience better for the patient so that they, like you say, get more of an outcome and an experience? So
yeah, some more brilliant questions coming in, Jen, but you crack through your slides and then I'll catch you at the end.
Okay, so I've alluded to it a little bit, but like I said, when I took on the role initially, I did take it on because I wanted a new challenge. And, I've admitted this to my boss as well as saying it on here. The job was a lot better than I thought it was going to be. And I mean that in all honesty. I thought I was just going to be answering a few calls and streaming some people, but actually the experience that I've had at Bupa has been phenomenal. And without kind of wanting to be a bit sort of Bupa heavy, from a mental health point of view, I cannot express just how much more support I have. And that's because obviously huge company, they have the setup to be able to do that. And in sports medicine, I always had support. I had a really close knit of people, and there was nobody's fault that I suffered that burnout, but actually there just wasn't the environment to be able to support that. So for me, having that support network has then allowed me to now do my job properly. And that sounds a bit cliche, but actually I've been overwhelmed with the amount of, true MSK kind of family that I've got now, and my clinical skills have just come on masses. So when I first started, I was a bit apprehensive and nervous, and I've put this slide up just, I think, to highlight that, if you are new to telephone or video consultations and you have some of these anxieties, then this is exactly what I felt, and exactly what I'm going through that experience, what I found was actually the reality. So, some of my concerns when I started, which has come up a lot, is that, you can't see the patient. How am I going to do the tests? How am I going to use all my skills to objectively measure and come to a conclusion? I can't use my hands. How am I going to do that? And I'm not sure how I'm going to be able to visualize what's happening if I'm just on the phone. I'm a bit nervous about using the phone because, well, I'm not used to doing that, and I can see the person, and I'm massively out of my comfort zone. So, although I took on this role, I did sort of think, oh, how on earth is this going to work? And I think when I talk about my job to people as well, these are commonly things that come up, and some physios that are potentially a little bit less savvy with technology, shall we say. And I've spoken to a couple of them in my village. They just can't understand what I even do for my job. They don't even get it. But I was pleasantly surprised, as you'll see, that what I found from a reality point of view is that it's really, really enhanced my therapeutic listening skills. The ability to tune into what a patient is saying when you can't see them is huge, I think, and it's really helped me and many clinicians, and same the colleagues that I work with. Patients do find it quite easy to talk on the phone. I think in some ways, although you feel it's a barrier, you've lost that nervousness of people coming into a clinic environment, especially at the moment. I've learned to be more specific in my triage. I don't think I waffle as much. I'm a bit of a waffler, but I've been a lot more succinct. Using my experience and my skills from previous roles, as I sort of started to talk about before, a lot of that has come right through, and especially now, sort of 8 months later, I'm a lot more comfortable in my actual role. All of this stuff is really starting to come through now, and I'm starting to bring it all in, which is really nice and helping my work. It sharpened up my diagnostics, absolutely, and it's made me realise that things are generally quite simple. And I know you spoke about it before, which was a great question, in that, do we as physio develop this habit of wanting to know exactly what's going on all the time? And my answer to that would be yes, because I've done it myself. We develop these habits of, wanting to triage and get all these serious pathologies sorted and pushing these buttons. But actually, if we take a step back, do we need to do that? And yes, obviously, I'm not ruling out anything that you need to progress, but I think it really makes you think about it when you can't see the person. And I found a new passion for my job. I think it's really helped me on a personal level as well as professionally. So that's nice. So these are my tips. Not many slides left, 3 left. So I just thought, what is easy? What can I tell people to do? I'm not a big, content kind of person, really, as I've alluded to a couple of times. I'm a simple therapist, a simple physio. And I think sometimes I think about what I would want to know. If I was listening to this talk, what would I want to know? And I would want to know, right, how can I bring this in and make myself a bit better? And what can I do? So these are just things. It's very much from my experience. I have no references. I've not done any research. I am interested in looking into it, as Jack's discussed. I'd be really interested to think about this in more detail moving forward, about patient experience and outcomes and things. But at the moment, this is just as a benefit from my experience in this role for the next 8 months. Sorry. You need to listen to your patient. Try not to speak over them. It's very easy sometimes as physios, when we feel we've got knowledge to impart, to talk over our patients. Actually, they've got a lot to say. And sometimes, and this is again another positive from a telephone point of view, is they just want to talk. You'll find that when people come into clinic, they just want to be there. Yes, they've got a problem and they need assessment and they need help. Sometimes these patients just want to talk to you. You can obviously do that on the phone. And if they want to talk to you for 20 minutes, then let them talk, obviously within reason. And I think you can get better at that the more confident you are, because I'm confident now I can let somebody talk for 20 minutes and do what I need to do in 10, but again, that's adaptable to your own experience. Treat it the same as if you're sat opposite them in clinic. Yes, you can't see them, but what would you be doing? Try and visualize it. Be open-minded, about what you can and can't see. Be descriptive. make it simple, you know, try not to go into complex medical terms. You have to keep it simple, because on the phone, you know, you can't always visualize what they're doing. I noticed some of the questions that were coming through when I was reading them before are about swelling, and, you know, how do you know how bad it is, and the heat, and get them to describe it, you know. And actually, if you think about it, what we need to do, and some of the stuff I've listened to from Joe Gibson and No Pain Mike, is that actually our communication and the way that we say things is huge. And I think we forget that sometimes. You know, your ability to be descriptive and getting them to tell you what the problem is, I think is massive. And I think this is something I've started to realize more recently, that, you know, if you can get the patient to describe to you what the problem is, it makes them think about it slightly differently. Now that can work both ways, you know, that can go and open a whole can of worms that you can talk to them about. But in my experience, sometimes it just gets them to think about exactly what the problem is, which you can then assess and talk to them with it. In the conversation about clinical testing, what I try and do is, I think, you know, have a good idea but from the end of the subjective chat about what I want to do, and then I maybe give them 1 or 2 tests. I do a squat and a single leg squat. Now, there'll be loads of people listening to this maybe that think, "What, is that all you do?" But actually, if I'm in a sports setting and I wanted to quickly diagnose how painful something was, I would get them to squat, I would get them to single leg squat, and I would get them to run and jump. And, you know, okay, that's not, you know, maybe, you know, the most scientific way to get in a very specific diagnosis, but it does tell me very, very quickly whether this is something that actually is just a little bit mechanical and maybe a little bit of overload, or actually if there's anything sinister going on there. Because, you know, from my experience in practice, if there is something sinister, that is not going to be very nice. And you'd see that in clinic anyway. So I try and pick of whatever body part it is, and maybe just pick a couple of things that's going to give me the most information within that time. Try to have a conversation instead of sort of checking on the computer. There's lots of chat about documentation on the questions, which is fine and obviously very important, but I think it's sometimes easy to fall into a trap of, you know, having your sheet and document in front of you and saying, right, what is this, and when did it start, and, you know, how, you know, where do you work, and, you know, give me a pain out of 10, when actually just have a conversation. Again, this gets better with experience, but if you can have a conversation and just jot notes as you go along and then quickly write it up afterwards, the patient on the other end of the phone gets a much better experience, and I think you get more out of them as well. Find your own process that works for you. Everybody's different. Don't compare yourself to others. Be confident. And I'll say this, you know, in my summary, you know, this is the key thing that, especially at the moment, I think, and running the group and some of the experiences we've had from the group, is people have lost their confidence, quite rightly. I think in some it's made people very nervous of working into face-to-face and doing new things like telephone and video. But actually, this is no different than anything you've been doing for a long, long time. And you're very passionate. And if you're clicking into all of these seminars and these CPD sessions, and you're on the Facebook group and you're listening to podcasts, you know, you're obviously conscientious. You obviously got at your job. And I think we forget that sometimes when, you know, something like is what's happening at the moment happens. Don't be afraid to say you're not sure. I did this yesterday. I turned around to the patient and said, "I'm really sorry, I'd love to help you. I'm really not sure what's going on." Now, for me, I have some easy options because I work with a huge MDT team. But for you, or if you're in your own, you know, that might be a case of managing that expectation of the patient. Maybe give them something simple to do and say, right, I'm going to book you back in. Let me go away and discuss this with some colleagues, and then we can work through it. You know, you're giving, and I think patients respond to that. Now, I can't sit here and tell you I've done that forever. I've only done that in the past few years, because I appreciate that that comes with experience and confidence in your own ability in some ways. But I don't think, and there's anything wrong with sort of saying, look, I need to get more information. Let's rebook this. Let's start with this exercise and see how you get on. Or I'm going to call you back tomorrow and just do that. And we do that all the time where I work. You know, I sometimes put people hold and discuss things with colleagues and things, exactly as you would if, you know, you're working in a clinic environment. You'd say, oh, can you just come and have a look at this? Okay, I think we need to do that more. Be aware of your pathways that we talked about. You know, where can you refer them to? Is there an option of face-to-face? You know, can you do an initial telephone triage and then give them some face-to-face, or can you refer to somebody that's doing that? Be friendly, be positive, and try and relax. I think that's easier said than done sometimes. So, last couple. So, I'm trying not to use all the buzzwords that I know Jack loves and he's going to fine me for. I think he's just going to write this book of all these podcasts that he's doing, and everybody that says, you know, new normal is going to get fined. We're going to get a big bill in the post, I think.
Don't make me cut your mic. I will do it.
So you'll be very pleased to know that I haven't said the C word once. So I've put new challenges in 2020, which I thought was quite innovative. People are nervous, and I think, you know, if you've experienced the Facebook group that we've got going, which is just a support network, people are really nervous, and I think that's totally okay. But I think what we need to do now is use all this guidance and use what we're doing and rebuild the confidence in yourself and the profession. Now, yes, there's new ways of doing it, the video, the telephone, you know, new PPE things today in you know, doing face-to-face consultations, but you know, you have been doing this for a long time. You know, it is essentially the basics are exactly the same. You know, whether you're a new student listening to this, you're a new grad, or you've been practicing for years, you know, you're good at your job. You know, we all have something valuable to offer, which is why people are coming to you. And from my point of view, confidence and your positivity is key. If you can get that across in a telephone consultation, your patient will buy into that exactly as they would do in a face-to-face. Okay. Closing slide, key things to take away: keep it simple, trust your ability, be confident, listen to your patient, and enjoy what you're doing. You know, it is different, and we do all face a lot of challenges, but I don't think that's necessarily a bad thing. And I think there's a lot that we can learn from this and move forward with. So.
Fantastic. Thanks, Gemma. That's absolutely brilliant. And I'm sorry we've no more time for questions, but I'm sure as she often does, she'll participate within the Facebook chat. So Gemma will get to your questions in text form, but we had that little lovely interlude where we did some questions in the middle, which was brilliant. So thanks, Gemma. That's great. I will stop the slide share.
That's great. Thank you very much, Gemma.
Jane, you're back on. Who have we got next?
So next up, we've got Steph Hewitt, who is joining us from Altrincham. So Steph works for North West Boroughs as an advanced physio practitioner and has private practice. And Steph has done her master's degree with us in advanced physiotherapy at Manchester Met, and is going to present some information from a systematic review that she's just had published. And there is a link on the Facebook page if you've not read it, but it is very apt, isn't it, Steph?
It is. Sorry, just remembering to unmute myself. Yes, so first of all, thanks very much for asking me, Jane, and for Jack for hosting. And I'm going to see if I can get this to share. Okay.
Get in there. Yeah.
Yeah, how's that looking? Right. I just need to find.
Oh, we've got it up on screen. It's just start presentation.
Oh, right, there we go again.
That looks fancy. Like Google's answer to PowerPoint. I've not seen
it. It is. I know, and it's completely thrown me because I emailed it. I'm on my husband's Mac, and I emailed it to myself in PowerPoint, and it's leapt into Google Slideshow. So I've no idea where.
Wish I could help you. Let's use the power of the hundreds of people that are watching to see if they can help you once you find it. Just for those that are watching on, it's really interesting how because of Facebook's privacy settings, especially for clinicians, it does show that it says between 100 and 150 people have been watching live. We've worked out that it's about 3.5 times that number that are live at any given time. So many thanks to nearly 500 of you that are joining us live. This will be available if you're only just tuning in. If you want to catch the rest of it, we've just had two brilliant speakers, Andrew Cuff and Gemma Oliver. This will be on our Facebook page as well as on YouTube as of tomorrow. So you can watch this back. We're just with Steph Hewitt. It's just finding how to press go on these slides and start slideshow. If any of you've got any tips and tricks as to how to do that. Top right, there should be.
Top right.
I'm in the top right. That's the
move the pictures.
Move me.
Present. Yeah, it says present.
Oh, right, got it.
There you go.
I was hiding myself.
We're in. I'll shut up then. Right, okay. You're on.
Right. So Jane said initially that I was going to talk about the apps that sort of I use, but if you're tuning in for that, then you're probably going to be a little bit disappointed because that's not what I'm going to talk about. As Jane said a couple of weeks ago, along with my co-authors, Ruth Sefton and Jill Yowell from MMU, we had our systematic review published on the effectiveness of digital health interventions in the management of musculoskeletal conditions, published in the Journal of Medical Internet Research. That looks at sort of web-based software and apps. And so as Jane asked me to focus on apps, I sort of extrapolated the data on apps, and I'll explore that a little bit more. So I appreciate the audience I'm speaking to, but just to add a brief overview from a musculoskeletal context point of view. Musculoskeletal conditions are the second greatest contributor to disability worldwide, and they account for 30% of GP consultations in the UK. In direct costs to the NHS, you're looking at 10.2 billion annually in the UK. And the burden is only going to grow, especially in light of this forthcoming sort of deconditioning pandemic that we're going to see as we come out of lockdown. The people that need activity the most are the ones that have been locked in their houses, and that can only sort of have a negative effect, if you like, from reports of musculoskeletal conditions. And so really this sort of review was about taking, if you like, a baseline of kind of where we are now from a digital health intervention point of view, as we need an integrated and strategic response that provides effective and accessible healthcare on a population level, and digital health interventions have the potential to do that. So just to give, that was a bit of background on MSK, a bit of background on digital health interventions themselves. The World Health Organization recently published guidelines on the classification of digital health interventions. And that was essentially their attempts to try and standardize the vocabulary within the diverse communities working within digital health, and to try and facilitate some kind of alignment across the different sort of implementations. So yeah, I'm talking about webs and apps here, but sort of you thinking about sort of implant devices, the spectrum of digital health interventions in health generally is absolutely huge. So they identified 4 key sort of digital health intervention groups: interventions for clients, interventions for healthcare providers, interventions for health system or resource managers, and interventions for data services. So obviously, for the purposes of this study, a digital health intervention is very much one that is an intervention for a client. Sort of the WHO's terminology also sort of expanded on that and sort of said to include targeted client communication, client-to-client communication, personal health tracking, on-demand information services, etc. So as I say, for the purposes of our study, it was very much the digital health intervention that was an intervention targeted for a client, and in our case was delivered either via web, via a website, or via web-based software. And we also stipulated that we needed some level of interactivity, that it wouldn't just be a flat website of copy, that there had to be some kind of entry sort of from the client, so that sort of the information would be tailored, even if only in the smallest of way, but it wasn't just a sort of flat copy on a website. Digital health interventions have the capacity to provide a high reach, low cost, readily accessible and scalable patient education and self-management interventions that can address both time and resource constraints, both of which we're short of. However, there is this kind of tension, if you like, between the dynamic development of digital interventions and the speed at which things happen, and the slow transition into clinical practice from more conventional clinical trial outcomes. And so that leads to the question of what constitutes an appropriate evaluation of a digital health intervention before widespread rollout. And this is the kind of concept that I'll touch on again later, this so-called digital exceptionalism, where just because something's kind of digital does it then sort of, is it not exposed to the same level of robust sort of rigor and examination than perhaps something more, in inverted commas, conventional would be? We need both clinicians and service users to have confidence in the effectiveness of any sort of app or website that you're directing them to. And ultimately, they have to work towards reducing the burden of musculoskeletal conditions. So for the paper, we used an awful lot of appropriate terms, sort of specific musculoskeletal conditions terms, and then terms like apps, website applications, etc. And searched Medline, Embase, Cinel and Scopus. The search was done in the middle of November of last year. We pulled out 22 papers that sort of met our inclusion criteria, but of those, 3 papers were on one trial and 2 papers were on another trial. So 22 papers, but 19 trials. We used the modified Cochrane collaboration tool for assessing the risk of bias. And then of those 19 trials, 5 were on apps. And so obviously that's what we'll explore a little bit more sort of this evening. Apps generally are gaining popularity. So one of the studies was done in 2015, but the remaining studies on apps came from the last couple of years, so 2018 and 2019. And just to say, there were absolutely loads of pilots and study proposals. So there's definitely more on the way. So if we just look in a little bit more detail at the 5 articles that were specific to apps and the management of musculoskeletal disorders. So this first one, this is the one sort of leading the way, if you like, from 2015. This is an American study by Irvin, and he did a 3-arm RCT. He had his control group, was no intervention, and then he had 2 experimental groups. The first one was using the FitBack app, which was an app based on CBT, with low back pain education and management strategies for episodes and prevention strategies for future episodes. They had weekly reminders and they had the app access. It was over 4 months, the length of the trial. The second experimental group was an alternative care group. So they just received 8 emails with links to various resources, but again, nothing specifically tailored, just kind of flat copy. On the risk of bias score, it didn't come out brilliant. It came out with a 2 out of 7. So the biggest problem pretty much all of our trials had, with the exception of one, is the capacity to blind. So there was only one study of the 22 papers that came out sort of as a low risk of bias in all sort of domains. But Irvin didn't come out brilliantly. However, from a results point of view, also just to say, we made sure we very specifically looked for the between group mean improvements. So we're not looking improvements from start to finish of the app group. We're looking for the difference very specifically between your 2 groups. So they got significant between group mean improvement for the current back pain, and then in functionality for quality of life and well-being as well. Sorry, and that I probably should have said a little bit at the beginning, we were very specifically looking at your 2 key indicators for or outcomes for musculoskeletal conditions, be it pain and physical functioning or sort of a disability. And sort of outside that as well, we did kind of look at secondary outcomes. And again, for Irvin, improvements in pain, patient activation, in workside outcomes, in attitudes towards pain and prevention helping behaviours. So when I did a little bit of research on whether the app is still available, I literally just looked in the App Store, it wasn't there. But I did find it mentioned in this global media corporation website. They've got a website in Oregon, and I could call for a trial, but given they only got 2 out of 7 on my risk of bias, I politely declined. The next 2 studies actually are from an organisation called Hinge Health. This first one by Shabib, so again American. It is from 2018, and this one looked at improving low back pain. It's 12-week digital care program provided through an app. It was 2-arm RCT. Their control group was a treat as usual. And they were given 3 digital education articles, which I'm not sure is a treat as usual, but anyway. But their experimental group was a 12-week digital care programme with sensor-guided exercises, with education, with CBT, with behavioural coaching, with an activity tracker and a symptom tracker over 12 weeks. So a really, really kind of comprehensive sort of programme of support for back pain. Their risk of bias was 4, they got 4, so it was 3 out of 7 was at a high risk, so sort of 4 from a low risk point of view. And again, significant between group differences in the CORV scale for pain and the VAS at 12 weeks, and significant between group differences for the CORV scale for disability and the Oswestry Disability Index at 12 weeks. And additional benefits on the secondary outcomes we looked at. So their impact on daily life, their surgery interest, their understanding of the condition, and their understanding of treatment options. So this study was done, as I said, by a group called Hinge Health, although they didn't actually refer to that name throughout the study, but the study I next go on to, they do. It's not in the App Store, but it's provided in the US through the employer kind of benefit funds, so very much through the sort of private health system. But clearly doing very well. In February of this year, they had a $90 million investment through Assume Venture funding. They were due to launch in London this year. Now I'm assuming that's probably been postponed, although could there be a better time to launch an MSK app than the situation we're currently in at the moment? So that's them. So they had that study on low back pain, but they also had a study by Mecklenburg, which is obviously also American, from the same year, 2018, looking at chronic knee pain. And again, a very similar setup. So a kind of 60-40 bias, sort of in favour of 40% in your control group, about 60% in your experimental group. So again, that sort of Hinge Health app, so your sense-guided exercises, both stretching and strengthening, education, CBT, psychosocial, personal health coaches, weight loss, activity tracking, text and email reminders over that 12-week period. So again, a really comprehensive sort of package of care for chronic knee pain. Slightly better on their Cochrane, they were 5. And again, it's that unblinded component that studies sort of in this area seem to particularly fall down on. Significant between group improvements for the Coos pain scale and for the VAS and for physical function with the Coos scale at 12 weeks. And then also they particularly focused on, as their sort of secondary outcomes, in interest in surgery, whether patients think they'll have surgery this year, next year, 5 years down the line, surgery interest generally, and came out with really positive outcomes for that as well. So as I say, that was the Hinge Health group. And then, oh, right, okay. This next study was by Chabra, so this was based in India, and they had a smartphone app called SnapCare, which I'm not sure about the term snap. Anyway, it's not what I would have called my app, but not to worry. So they had a smartphone app in self-management of chronic low back pain. Did I just go mute then? So two study groups, fairly similarly sized. The control group, written prescription from the physician, which includes medicines management and recommended levels of physical activity. And then from an experimental group point of view, as per the control group and the SnapCare app, which was daily activity goals, home exercise program, and recording the pain levels after each activity for 12 weeks. They were actually, it's a really nice little study from a risk of bias point of view. It was single blinded study. Obviously the participants weren't blinded to whether they got the app or not. Significant improvements in the modified ODI at 12 weeks, but no improvements in pain. But again, we're dealing with a chronic pain population. You wouldn't necessarily expect improvements in pain over a 12-week period. So I think they've done well to get their improvements sort of functionally. SnapCare app, I can't seem to find it anymore, not in the App Store. Okay, just did a bit of a quick Google search, but sort of no sign that it's going, which is a shame because it's, as I say, it's a nice little study. And then finally, the most recent app-based study is a German study by Toel et al. From last year, and looking at app-based physio versus sort of more conventional non-app digital approach. So the control group, again, this is quite a nice study, because I felt the control group was a sort of a reflection of sort of more accurate reflection of standard care. So they had physio sessions, which included exercises and manual therapy every week for 6 weeks. And they were given links to the websites, weekly emails, sort of detailing online resources, and brief motivational messages. So really everything apart from the app. And it's this Kaya app, which has had a bit of press. I think it was in Physiotherapy when it was launched. 3 modules, 1 focusing on back pain specific education, 2 on exercise, and 3 on mindfulness and relaxation techniques. And they had that for a sort of 12-week period. Risk of bias was 4, so high risk in 3 categories. Again, blinding was where this one fell down from that perspective. Improvements in pain, but no improvements in the Hanover Functional Ability Questionnaire. The Kaya app is available in the App Store. It'll cost you £60 a year if you are so inclined. So those were the 5 studies that we found from our literature search that sort of involved the use of apps. A little bit more sort of rounded from the results point of view. Of the 19 studies, so obviously this is including the web-based software stuff as well. 9 showed statistically significant between group differences for improvements in pain, and sort of in the subgroup of the apps, it was sort of 4 out of 5. Of the 16 studies, so there's only 16 of the 19 that looked at functional disability, 10 showed statistically significant between group differences. And again, 4 out of 5 for the apps, but it was a different 4 to the pain 4. All app delivered studies produced positive outcomes for pain and or functional disability, which is great. The in-app functions, and this is something that the literature does tend to indicate, sort of that capacity for the patient or the service user to interact and have a little bit more support. So in-app functions such as your sensor-guided exercises, notifications, your daily activity goals, all of that kind of thing does seem to really facilitate greater engagement with patients. Another plus of apps is their ease of access, their portability, and their convenience in comparison to some of the web-based interventions. So some of the web-based interventions that perhaps from a few years ago when technology wasn't quite where it is now, were very kind of really quite labour intensive, and they involved people to do essentially what we encourage sort of a lot of our chronic patients not to do, as in sit in front of a screen for a long period of time and work their way through modules online. And perhaps unsurprisingly, their outcomes weren't as great. And I think that sort of that portability of an app and the convenience to dip into and out of it is what makes them perhaps more successful. It's really difficult to draw direct comparisons between the studies. So when we looked at those 5 app studies, there were 21 different outcome measures, and take that out sort of broader to all the included studies. And we had a ridiculous number, quite frankly, of outcome measures, which is a reflection of MSK generally, but also to a certain extent a reflection of sort of the digital technologies as well as so many ways of measuring outcomes from their point of view. Additional support such as text messages, emails were definitely associated with better outcomes, but there's a real disparity between the frequency and the delivery mode, so it's really hard for us to draw any specific conclusions other than to say they do seem to be associated with better outcomes. And in all cases, and this is one of those negatives that you try and spin as a positive, digital health interventions weren't inferior and caused no adverse effects. So they are, yeah, so even if they do nothing, they're not doing anything worse than sort of more conventional interventions. So sort of conclusions, apps, digital health interventions generally, and apps in particular, demonstrate clinical benefits in the management of musculoskeletal conditions for both pain and physical functioning, more so physical functioning if we include the web and the web-based software in that as well. Apps pretty even. They have the potential to contribute positively towards reducing the multifaceted burden of musculoskeletal conditions individually, economically and societally. Accuracy, quality and appropriateness of content, which sounds really obvious, but it's about matching the complexity of health education with the service users' needs. And not so much with the apps, their content was pretty good, but when some of the web-based stuff, essentially they didn't get great outcomes, but when you actually looked at what the intervention was, it wasn't sort of in line with current best practice guidelines. So unsurprisingly, it didn't work, and therefore it's quite, there's the potential that you would dismiss the benefit of a digital health intervention simply because, not because of the mode of the intervention, but simply because of the quality of the content that is in that intervention. Accuracy of health information and clinical content is really important, particularly for such prevalent conditions of musculoskeletal conditions. We know there's a disparity sometimes between what the evidence says and what the service user or patient thinks, and you cannot have any intervention but a digital health intervention adding to that disparity. Apps have the ability to deliver safe, high reach, low cost, readily accessible and scalable care. And they address things like physical access issues, so physically getting to the hospital. Anybody, I work out of St Helens Hospital, and okay, things are different at the moment, but in normal times, you know, you're dealing with patients that arrive half an hour late because they've had half an hour queuing to get in a car park, and then they don't have to walk from the car park, come down all the stairs to our lower ground floor therapy suite. You know, and that adds to, it's not a terribly pleasant experience for patients struggling to walk. Also sort of issues like comorbidities, travel distances, costs, etc. So it has the capacity to help sort of address those issues. Due to the heterogeneity of the app interventions, it's really difficult to draw conclusions as to an optimal dose or an exposure. As I said earlier, there was definitely some of the web-based stuff that required an awful lot of time from patients, and they didn't respond well to it, or they sort of dropped off fairly quickly. So it's hard to kind of say this is how much, exactly how much dosage is needed in order to gain clinically meaningful benefits. I put a sentence in, I think, my conclusion that said healthcare systems currently stretch to such an extent that the frequency of delivery of face-to-face appointments is suboptimal. That's me almost predicting the future, because definitely things are suboptimal at the moment, but that there was definitely a sort of an indication that their role as an adjunct to face-to-face is probably where that they will best sit, as opposed to any kind of replacement. Ultimately, with sort of the difficulty accessing services to a certain extent at the moment, patients may well find themselves dipping into the app more frequently, which ultimately means they will be accessing more healthcare than they would if they solely relied on face-to-face. We need a greater depth of transparency regarding the achievement of how individualized patient content was developed, so the stratification or the tailoring of detail to patients. We don't know whether it was just done, sort of, they all kind of said, oh, we tailored, we stratified it, but they didn't say whether that was purely done on symptoms alone, or whether they were taking in sort of the demographics of the patient, the educational level, their age, etc. And this is relatively new technology, so then it sounds a little bit daft saying, but there is that lack of longer term follow-up. And I do think what would be really, really interesting is to see sort of whether patients are then, you know, sort of future episodes, exacerbations of, you know, of an acute on chronic, can they then go back to something 12, 18 months down the line and self-manage without needing any kind of sort of intervention. So this study was done and accepted and completed as we went into lockdown, essentially. So I've just tried to apply it to the totally different landscape that we now find ourselves in. This is just a slide that shows the kind of research spend, or the financial investment, if you like, in conditions generally as a result of the burden of the sort of burden of disease. Comparatively, musculoskeletal conditions have never been as well supported financially per burden of disease than other areas of medicine. And despite the fact that we're sort of facing this deconditioning pandemic, I can't see that changing. Therefore, it means we have to be as innovative and open-minded and creative as we possibly can, and really try and utilise all the tools that we have available to us to manage our patients as effectively and safely as we can. So kind of, as I've alluded to, the sort of the people that have been shielding and isolating are the ones invariably with the most long-term health conditions that we know activity is crucial for. And the older you are, the more important activity is to you, and that's going to be taken away. So I only see MSK complaints rising, and we need as many effective tools as we can at our disposal. From the evidence, there is evidence to say that good apps will work, but we don't actually seem to have the tools available yet to provide something on this scale that would contribute effectively to the management of MSK conditions. But it is an exciting time for development and innovation in this field. So final thoughts for people looking at apps, sort of thinking about maybe they can incorporate them in their clinical practice. Do consider the concept or the idea of digital exceptionalism. So as I said at the beginning, this is the idea that somehow digital medicine is different, that it doesn't have to be exposed to the same level of rigor and questioning that maybe more conventional stuff does. So digital producers are very good at obviously coming up with their digital outcomes, and obviously we are much more interested in our clinical outcomes. So it's just being aware of that potential mismatch. Future successful clinical development will be rooted in strong links between digital developers, clinicians and patients. And our outcomes have to be clinically centred and patient-centred, as well as being digitally centred. So an app needs to deliver digitally from a functionality point of view, but its content has to be grounded in the current evidence base and the best practice guidelines. I think there needs to be an acceptance that there will never be a finished product. There needs to be constant evolution on a clinical front and a digital front, so we need to be able to quickly adapt and react to sort of changes that come in. As I said at the beginning, the World Health Organization sort of attempted to clarify their terminology. NICE have fairly recently produced their evidence standard frameworks for digital health technologies. However, is that sufficient to differentiate a really efficacious digital product from commercial opportunism? So we have to bear that in mind as well. And I would say, if you are considering using apps, look at the research. I was quite surprised that there were only 5 RCTs published on this. I was thinking there were more. As I said at the beginning, there is loads coming our way. I don't think we could reproduce this study even now. I just think there'd be too many papers. I think you would have to split it down into purely apps, purely web-based software, purely websites. So there is a lot coming our way, but I would say look out for the research, take responsibility for examining the evidence base, and look for a demonstration of clinical effectiveness and economic impact. So questions? Sorry, rattled through that.
Thank you so much, Steph. That was brilliant. we're struggling for time for questions now, but there's some great ones on the comment section. And if Steph, if you get a chance, if you can jump into there either now or afterwards, that'd be fantastic. Certainly signposting to the Orca website, as well as then people are mentioning patient resources. There's always mskr.info. If you've not spent any time on there yet, then please do take a look. That's ever growing resource there. And thank you for, I mean, it's just something that really fascinating with regards to the research of it. People don't always think that. They think they're just any shiny gadget or gizmo is going to be really useful. And so they sometimes jump on and latch onto the new thing, which might be apps. And so for us to then have that deep dive into the research for it has been fantastic. So thank you, Steph. Jane, would you like to introduce our final speaker of the evening?
I'd be delighted to. Thank you, Jack. And thanks, Steph. That was brilliant. So good morning, Pam. I don't know what time it is in Sydney, Australia, but I'd really like to welcome Pam, who has an amazing wealth of experience in delivering online exercise and engaging people from maybe communities that already have to socially distance to some degree. So yeah, I won't waffle on. I'll hand over to Pam, and thank you so much for joining us at some ridiculous hour of the morning in Australia.
Thank you, Jane, and hello, everyone. Yeah, it's not too bad now. I mean, I've been awake since 4, but it's 5:45, which is more respectable hours, but I do run the risk of my kids waking up now, so fingers crossed that's not going to happen. Thank you for asking me to speak, and I'm sorry I missed the first 2 presenters. I'm going to have to watch it back, but really enjoyed Steph's presentation just then. I have got a few slides for you, which I'm going to screen share. I have to apologise in advance that I do struggle a bit with word finding difficulties first thing in the morning. So sorry if I bumble a bit and a bit bedhead going on, but hopefully I'm going to be able to share something useful with you. So yeah, thank you to Jane for asking me to speak today. I am a respiratory physio by background, so feeling a little bit out of my comfort zone presenting to you all. But the reason I've been asked to speak is because for the past 4 years, I've been offering online exercise programs to the cystic fibrosis community, which is how I know Jane through a previous role that she did. And through delivering those online exercise classes, it's kind of given me a lot of opportunity to learn about tech, remote support, and patient engagement. So what I am hoping to cover with you today, kind of having in mind that some of you are going to be looking obviously into developing your own digital services and solutions, and perhaps you've already been hosting some of your own live group exercise classes, perhaps for perhaps your back pain classes, OA knee classes. It's a long time since I've done musculoskeletal, but that type of thing, maybe you've got those running up. I wanted to kind of give you a little bit of background as to what I've learned through offering live and on-demand exercise classes over the past years, and some things around how to improve engagement with those sessions, because you may have found that already, like, people are interested in them, they're excited about the fact that this can kind of come into their home, but you may be a little bit concerned about whether or not you're going to be needing to offer these longer term and how that might look, and also how you're going to manage to maintain engagement with those classes longer term as well. So a little bit of background to me. I'm a physio. I worked in the NHS for 15 years, predominantly with adults with cystic fibrosis. I always had a passion to better understand adherence to therapies, the role of exercise for physical and emotional well-being, and ways to streamline services and improve quality of life. I'm also a yoga teacher, and I explored yoga for thoracic kyphosis and low back pain in adults with CF for my master's dissertation. I'm a campaigner, and the reason that's relevant is because it's very much kind of led to where I am now. I ran, when one of my best friends was waiting for a lung transplant, I ran an organ donor, a campaign to raise awareness of the shortage of organ donors. And that was obviously a remote campaign that I did, and it saw a big spike in the increase of people signing up to the organ donor register. And that kind of showed me that actually I don't need to be in the room to facilitate behaviour change. You can facilitate behaviour change remotely. And I am the co-founder and clinical director of Beam. We're just a little team that scattered around the world. We're a global team. So why did I build an online exercise platform? After I'd been doing my master's and wanting to offer yoga to my patient group, I was questioning how I was going to do it. So people with cystic fibrosis, as Jane inferred, have been having to social distance for decades because of the risk of cross-infection between them, which can have a negative impact on life expectancy. And also that presented the need for infection control measures, made things challenging for me as a clinician for how I was going to be offering exercise classes in a cost-efficient way, and also in a way that was good for patients, that didn't involve them having to travel hours up to their tertiary centre for their specialist care. So it kind of made sense to me and my patients to look at an online way of doing things. And I'd had this experience of like tech for good and seeing that it can influence behaviour change, and an opportunity presented itself where I got to, where I met Katie Bell, who is my co-founder on Beam, and she's a technologist and social entrepreneur by background, and she could build a platform. So this is what we do. This is us. We're an online exercise platform for people with specific health needs. We offer live and on-demand exercise classes led by people living with or working in a condition, and we offer community and motivational support. As I'm going to be going through this presentation with you today, I'm going to be talking about things that you can adapt and put into your practice, but I am going to be talking about some of the lessons that I've had and things that that's prompted us to build out certain features on the platform, because that might help you in your thought process as to perhaps what digital solution you choose to engage with or create as you're looking how you can support your MSK patients better. So we currently, our main focus today has been supporting people living with cystic fibrosis. Today, we've just gone live on the platform for kidney rehab, and we have a bit of women's health content there as well. We've always worked in collaboration with clinicians, from co-design and developing through to piloting and collecting health outcomes and building like the health economics of the product as well. So cystic fibrosis, we've worked with the ACPCF, the Cystic Fibrosis Trust in the UK, the CF Foundation in the US, and big centres in all places. Kidneys, happening with Kidney Research UK, and leading renal rehab clinicians across the country. And we're also working on cancer as well. So our exercise classes are tailored to specific complications, symptoms that people may be having, but they are also around general kind of fitness and strength and conditioning too. So we were initially called Paxter, and it was only 6 months ago that or September last year, that we became Beam. Time is a strange concept at the moment. And the reason that we had this change in name was because, like I said at the beginning, like when we launched our online exercise platform, there was a lot of initial kind of positive engagement. People were thinking this was going to be great, great solution, going to make life a lot easier. Lots of people signed up. Some of those people went on to do the first classes, but then we had a massive drop off in whether people were coming back to the platform and continuing to use it. So we applied for an Innovate UK grant to develop the behaviour change features on the platform. We, with that grant money, we were able to hire a couple of behaviour change researchers to interview people who in our community who were using the platform, who weren't using the platform, to understand their barriers and facilitators around exercise, and to try and understand how we could support them better. After we went obviously through all this data and analysed the themes, we had a steering group that involved people from the specialist interest group, the charities and some of the centres and patients. And yeah, the thing that came to the surface to engage people better with exercise was to not call it exercise. So very much like the work from the CSP, the Love Activity, Hate Exercise campaign. And we'd been thinking that when we applied for this grant, that we'd be getting like some great tech ideas as to developing personalized algorithms and how we could use, you know, push notifications or whatever to sort of nudge people into healthier behaviors. But yeah, we ended up having to rebrand and change our voice, reframe exercise, redo basically the whole site. So it was turned out to be quite a big undertaking. So our voice now, we're called Beam because we focus on the feel good. That was a thing that most people said motivated them. They knew they needed to do exercise. It didn't make them do it, just having the education, but the feeling of satisfaction after the class was the thing that often spurred them on. So we focused on that, and we've had to change our language from talking about exercise and workouts to talking about activity and sessions, and we want to be like that that accessible platform where you can come and you can have knowledgeable advice, but you can still be supported and by someone who is compassionate and empathetic to the challenges that you're going through, because we work predominantly with people with long-term conditions. And so you'll notice that on our website, like that's the tone of voice we have, and we use these illustrations as a way to make the platform feel more accessible to people who don't identify as exercisers and who may be intimidated by seeing someone fit and well doing a workout that's not how they feel about themselves. So we offer live and on-demand exercise classes, as well as the community and motivational support bit, but this is the bit that I'm going to focus on now because I think it's going to be particularly relevant to you. So creating your, for those of you who have already been doing this or who may be thinking about doing it, creating on-demand exercise videos that can either be hosted on a website or you put on YouTube, they can be great. Like they can be available for people to do anywhere, anytime, kind of the convenience will fit in with their schedule. Obviously, there are lots of pros and cons to all of these things, but I've just highlighted one of each. A big downside with the on-demand content, if you're just putting it out there on a mainstream platform like YouTube, is you're not going to know whether or not your patients are actually going and doing those sessions. And they don't have the accountability. They might know that you're not checking in unless you're doing one of the apps that's been mentioned where they've got their prescribed treatment program prescribed. So just creating videos on its own, it can be really useful, and people will, if they're your patients, they may well love to see you being the person delivering that content because they trust you and that resonates with them. If you're thinking about filming some videos, some things to have in mind is what equipment that you're using, and you can spend a fortune on filming videos as far as like getting videographers in and having good lighting and audio, and good lighting and audio are key to making a successful video. But you don't necessarily need to go all out on the tech. Like a lot of the phones obviously can create great video content, and with some wireless headphones perhaps you'll be able to sort out any audio issues. But also, if you're going to be making these videos, obviously thinking about where you plan to host them so that they have best engagement, and so that you can, if you're wanting to track people's engagement with them, like you're able to do that. Obviously delivering the instructions, thinking about how you're going to offer those modifications. And you'll know, like if you're targeting these videos at particular cohort of patients, you'll know perhaps some modifications that you want to do, but you are more limited in being able to think about other, if it's just a video, then if they've got other comorbidities or other injuries at play, then you're not able to like personalize them kind of beyond offering some like different intensity kind of modifications. The other challenge that we have, or thing to think about when it comes to creating video content, is people get bored really easily. So needing to keep it fresh and interesting and keep adding new content. So this is on our site. This is a screenshot from RCF stuff. And as you can see there, our sessions are tailored towards specific things that a person with cystic fibrosis may have issues with, like pelvic floor or postural changes or something, but the sessions are normalized to make it kind of normal exercise. We want people they have a huge burden of treatment already. We want it to feel fun and normal and engaging, but still have that kind of evidence base behind it where available, where possible. But we do try to give these sessions relatively normal titles, and the clinicians are in normal clothes and in normal environments because we just want to make it normal, even though exercise is medicine. When it comes to live classes, they provide a really great opportunity to have more interaction. So for those of you who are doing this already, I'd love to hear your experiences. They provide an opportunity before and after class to connect with the people in the room. there is like an ideal number of people. If you have like 40 people rocking up to your class, you're going to struggle to properly form connections, and for them to know that they're there, or for you to be able to kind of tailor it to people in the room. But they also provide a social opportunity for people who, especially people who are having to shield, or the older population who are at home right now, and who are deconditioning. You know, coming online and doing live exercise platform could be a tick the box of getting them moving and giving them some social interaction. But it can be hard to fit into someone's schedule, because you're still asking them to show up on a given day at a given time, which might not fit with how they're feeling at that point in the day. So considerations with that, what technology you're going to use. And I'm hearing so much conversation around use of Zoom or Microsoft Teams and other video conferencing technology. We integrate Zoom into our platform. It's because it's integrated into the platform, there's some extra levels of security. So we feel good about that, but I know that some trusts just don't support it. Yeah. All the different platforms will obviously have different features, but using one where you can see your grid of people in the class is obviously really helpful. How are you going to manage assessing people before class and them coming through? Whether you're going to do one-to-one consultations before they do a group exercise session with you, or whether they're going to turn up for the first session and you're needing to kind of do a bit of a screening with them there and then. Again, I don't know kind of what's going to fit into your practice, and but we do have people because we host classes that are open for anyone to join. The way I have had to introduce some screening is by using the poll function in Zoom. So I will ask people about certain precautions and contraindications around exercise with that. And if they have any issues, then I'm asking them to message me directly before the class starts, so that I can manage it. But you will have your information governance and things that you feel comfortable doing around that, as to whether you feel that's something that you can do. How else are you going to evaluate progress? Check-ins with people. So whether that's asking people, like for a patient reported outcome measure at the end of a class, or tracking. I mean, we've got it built into the platform that people score it, but how are you going to be facilitating that? Other things to think about: group dynamics. This can be a really interesting one, because the social element is so important, and especially for people right now. But I mean, I work with people with long-term conditions where sometimes when people are at different stages of the disease, the conversation about what one person's experiencing can be quite triggering for someone else. And it could be just, you know, conversations in general. It's not like you can take someone off. You're not in a real space where if someone's having a conversation with you can kind of take them away from the rest of the group. The conversation is there for everyone to hear. And so you do need to be, if you're leading that class, you do need to think about how you're going to moderate that conversation and how you're going to manage confidentiality. And I mean, if people are consenting and signing up to this group, feeling maybe they're feeling okay about it, but how do you feel about those conversations that take place? And maybe you want to set some rules before the class starts as to what is acceptable, like things to talk about in that space. And if they've got anything clinical, then they need to sort of bring that up with you in another format. And how you're going to track attendance. So again, we've got this built into the site as a way for us to see who's coming to our classes and how many sessions they're doing. But for you, maybe you're able to download the attendance report from the video conferencing software that you're using. I know sometimes if, like with Zoom, you don't necessarily have to put in all your details, you might not see someone's names. So is there a way that you're going to kind of keep track of who's coming to which classes? Few things about teaching those live classes. These are like pretty obvious pointers, but it's teaching live classes does have a very different feel to being in the same room as someone. You don't get to pick up on the energy of the group, especially if you've asked everyone to turn their microphones off when you're teaching, so they're not disturbing one another. So yeah, I'm going to state these. So tech setup, audio and lighting again is key. do a test run of your class at a time of day that you plan on teaching your class, so that you know that your lighting's okay, and you know whether you've got echo in your room, that kind of thing. Preparing your space, making sure that it's aesthetically pleasing if possible. And you've got enough space to kind of demonstrate whatever exercises you want to do. Planning your class is obviously like you do that up front before you even decide that you want to go ahead and run live classes. But what is the purpose and what are you trying to get out of it? The great thing I find with live classes is that you can be really responsive. So if it's with things are changing so quickly at the moment, whether it's, you know, people having to shield for longer, or new anxieties that are coming up, or new issues that you're noticing and present itself, like you can quickly adapt and rechange like the focus of a live class, and who you want to attract in it and how you're going to. So you can allow yourself to sort of have some creativity there. Teaching online and managing a group. So things that I touched on before, like how you're going to manage multiple levels. Are you going to like really refine down and have exercise classes at for certain people at certain points with their health condition? How are you going to manage adverse events? How are you going to keep safe space? And how you're going to promote your class. So that if you're not seeing people in clinic at the moment, how are you going to be getting word out there? So we use our we use our clinic links to do that, but we also go through our charities, and we also use our own social media engagement and so forth to try and get word out. But hopefully you've got your mailing lists, and you've got a referral process who you're directing this to specifically. So this is some feedback that we've had from people who are attending live classes, and generally like some people are wary like of coming to a live class. We often have to reassure people that you don't have to have your video on the first time, you can just come and watch. But those who do come along do really enjoy them, and often it is for the camaraderie aspect and the being in a room with others going through what they're going through. They also, compared to maybe doing an on-demand video, will find that perhaps having a live instructor pushes them a bit more. And people often say that they like the fact that they can ask a clinician questions. We also have we have groups on our site where people can like follow up a conversation. So a hospital or a clinic can have, or an instructor on the platform can have a group where they can continue to have conversations with the people who were in the class between sessions. And we use that to try and encourage motivation as well as share kind of other exercises that they might want to try. So some other feedback, this was a lot of these points obviously come up just generally through constantly. This is like our main thing that's on our mind all the time. So we're constantly learning, but we also carried a pilot in the US at the end of last year with 4 of the major CF centers there, and collected patient feedback. So some things around that. Motivation is a key element of maintaining physical activity. There you go. An obvious statement there, but it's true. Just because you build it does not mean that they will come. You have to work hard to keep them engaged. And obviously, like your messaging and what you're communicating is key to that. We also use tools to get people started in the first place. Of course, like people that I see on the platform will have seen a clinician probably, because they will have at some point in their life because they have long-term condition, and teams have physios in them. But we also support them to think through using motivational interviewing style questions to get them thinking about what are their motivations, their barriers, like what's the first step they're going to take, that kind of thing, getting them started. Some people, so these in the purple boxes are quotes that we had like on our evaluation. So some people were asking for those texts and reminders. So interesting to hear Steph saying as well that was influential in people sticking with programs. we've got the functionalities for people to be able to schedule and put sessions in their diaries, as well as kind of save them to come back later. And we're a web-based platform at the moment, but we're just about to launch our app that kind of will facilitate like more nudges and things too. But how are you going to be sending out those reminders to your patients basically to show up? And I mean, I said it doesn't mean that they'll come. And this is on that same note, like just because you've suddenly like this, you think this is great. I've created a virtual space for people to exercise, and we can have more people coming through more quickly now. And perhaps they don't have to pay for it. And you think that's like a no-brainer. They're all going to sign up. Obviously, just because you have it doesn't mean that people are ready to start taking those steps forwards and of incorporating exercise into their day and their routine. We've definitely seen that when clinicians, so some of our sessions are on-demand sessions or are exercise sessions that are led by just generic instructors. Like we've definitely seen that when a clinician leads exercise classes to their patients, they get better engagement, or if a clinician does on-demand videos as well, they tend to get better engagement with their patients, in part because the patients quite enjoy coming along and seeing their physio exercising. And some people have definitely commented that they found that quite humorous to do a class with them in that way on the internet. Like there's a bit of novelty value with it. And of course, the fact that they can ask the questions and from their clinician there and kind of get answers and know how to progress things versus the video. We've also seen like for when people, we have the opportunity for people and clinicians to see a data dashboard so they can see which session, how many sessions they're doing, when they're attending, and which session, like we have some soft kind of feel good scores like before and after class and things, because some of them are general activity. The people who consent to sharing their data with their clinician see they are 4 times more active on the platform than people who don't on average. So sharing of data has had a massive impact on what people are doing. Activity tracking, so being able to see what they're doing. So whether this is you encouraging people to use some apps for keeping track of what they're doing online and offline, or something else. But of course, when it comes to long-term engagement with exercise, that can be helpful for some people, as long as it's easy to do. Yeah, that's something that we're doing at the moment. We currently track online activity, but we want people to put on what they're doing offline as well. So it's kind of quick whiz through. This is just a picture of us and our team. All this is like online exercise is, like I said at the beginning, it presents presents challenges. It's not an immediate sort of easy win, and there is a lot of follow-up that's involved. And the reason, like, so this is our team that's kind of spread around the world, and the reason I'm showing you this is because, like, for us to do this work, we do have a data analyst and marketing people and the tech people, and these studio managers, like the 2 people here on this side, Natasha and Olivia. We've just had to recruit these guys as studio managers for the platform, because actually the setting up and the running of these sessions is time consuming, and making sure that everyone's confident in having the skills to kind of teach classes as well. So I hope some of that's interesting and relevant, yeah, those are our handles and the MMU courses. And I'm interested to hear, Jane, what's happening kind of with regards to digital health programs at MMU as well.
Yeah, great question. I think it will be ongoing, and hopefully will be embedded into our undergrad and postgrad programs more so after now. But yeah, thank you very much. So I think really, do you want to say anything, Jack?
Always got something to say. Yeah, no, it's been absolutely fascinating, and we've covered such a massive amount of ground. Thank you so much, Pam, for joining us, especially so bright and early in the morning. And you offered so many apologies at the start, and absolutely, you shone. So fair play. The first thing in the morning, it's been fab. Now, one of the things I think would be smart for us to close, and we will need to wrap up. Unfortunately, we can't do as many questions as we'd like, but there's been so much commentary on the Facebook chat that two things I think have happened. One is that we will try to get to those questions, and you're also answering them amongst yourselves. But secondly, it's kind of shown that we will need to do this again, or something similar. I think it's been a really interesting hunger for this format, and it's been fantastic. So what I think we'll do though, Jane, is we need to bring up your final slide, which is important sort of signposting for the future, and certainly for everyone to pay attention to what MMU are doing, who have been one of the most innovative universities before all of this, but also they therefore got going with a lot of the online learning across all their undergraduate, postgraduate, and the way in which they're remote working, even for their PhD students, has been fantastic. So please do make sure you scan away at those codes, take a photo of this if you're still watching, or if you come into this not live, then make sure you have a little look, and make sure you pay attention to all things MMU. Following them across social media, especially on Twitter, is a great account. I also think that what we need to be sure to understand is that this conversation is something that is a constantly ongoing and moving picture, where virtual consulting, telehealth, it's something that we need to make sure we're sensible in how we collect the data, and therefore use this bizarre situation and tragic circumstance in many ways as an opportunity when appropriate. And it's sometimes sensitive for us to talk about that, but both as a profession and as an industry, we need to recognize how to create a sensible nexus between virtual consulting and then face-to-face care, without the absolutism that can sometimes come from people forming new tribes and camps. And so the best way to do that, the best way we know, is through conversation. So we're massively thankful to MMU for bringing this forward, and of course to you, Jane, for making this happen. So thank you so much.
Thank you. And yeah, thank you very much to all of our speakers. I think, just to reiterate what Jack said, it's been fantastic, really varied, and lots to take away from it. So yeah.
Thank you, Steph, for the cameo there from your daughter, I assume. You're all very fortunate that I've not got two crying twins on me. They're fortunately tucked up in bed and doing well. But I need to get off for my tea, so we'll wrap up there. Thank you all again, and we'll all speak soon.
Thank you.
Cheers. Take care. Night, everyone.
Bye, everyone. Bye. Bye.